Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
When it comes to back pain, you've probably heard the term herniated disc, sometimes called a slip disc or a ruptured disc. A herniated disc refers to a problem with one of the rubbery cushions or the discs between the individual bones, the vertebra, that are stacked up one on top of the other and that make up your spine.
I have heard that spinal disc is kind of like a jelly donut.
Well, you know what? You're exactly right.
Yum!
It's got a soft center encased within a tougher outer layer. And a herniated disc occurs when some of that jelly, that softer part, pushes out or herniates through a tear in the tougher exterior. Exactly right, like a jelly donut.
Doesn't sound good. A jelly donut does sound good.
I think so.
A herniated disc can irritate nearby nerves and result in pain, numbness, or weakness in an arm or leg. Here to discuss treatment options is Mayo Clinic orthopedic spine surgeon Dr. Brett Freedman. Welcome to the program, Dr. Freedman. It's nice to meet you.
Hello, guys. It's great to be here.
Always nice to have one of my colleagues on the show, isn't it?
Absolutely.
Yep. Dr. Freedman, great to have you with us. So when we talk about herniated disc or slip disc or ruptured disc, do they all mean the same thing?
They do. It's different common terms for the same idea. And so that jelly donut has an outer rubbery ring and an inner gooey center. And if that rubbery ring breaks or fails for any reason, that allows the gooey center to come out. And as it comes out, it can start to push on nerves. It can cause both pressure as well as inflammation on the nerves, producing symptoms both in the legs and also in the back. But all those terms would be indicating the same kind of phenomena, which is that the disc, that rubbery cushion between the spinal bones, has failed for some reason and has resulted in some pressure on the adjacent structures.
Unlike a jelly donut, though, which you can fill back up with more jelly if it happens to squirt out, I don't suppose that you can put that filling back into the disc.
Yes. My daughter would be very disappointed. She's a very big fan of jelly donuts, and there's no jelly back in this donut. You're born with what you got, and when it starts to come out, then that is lost to your system. That jelly will dissolve for many different reasons, aging being one of them. But certainly with any type of disc herniation, once it's gone, it's gone. And one of the treatments we do for disc herniations, discectomy, we typically try and preserve all the remaining good jelly inside the donut.
So how many discs do we have?
We have 24 different spinal bones, and between every spinal bone there's a disc. The ones that we're most concerned about are going to be in the lumbar spine. And
so that's the lower back. But a herniated disc can occur anywhere, correct?
It can. And so it can happen anywhere from your C2-3 disc, which is your highest up disc. It's right below in your neck. Mm-hmm. All the way down through your thoracic spine, your chest area, although those are quite uncommon. When they do occur frequently, we just watch those. And then the most common type that are symptomatic, affect us on a daily basis and affect our ability to go to work are the ones that occur in the lumbar spine, so between the L1 bone and the L5 and S1 bones.
Now, you mentioned that age is one of the risk factors. Are there others? I mean, are there certain people who are more likely to have a ruptured or herniated disc than others?
It mirrors what we see with generalized lumbar spinal disease. And so certainly one of the biggest risks is being overweight. And so weight control is an important piece of the process. A sedentary lifestyle is a risk factor onto its own. And the reason for that is we actually have more pressure on discs when we sit down than we actually stand up.
Isn't that interesting? Say that again.
We have more pressure on our discs when we sit down than when we stand up. And so our spines weren't really designed to be sitting for hours at a time. And then there are certainly genetic factors. Sometimes this runs in families. There's things we do, like, for instance, smoking, which hurts the quality of our tissues, and so that can increase the risk as well.
Did you say family history or no?
I did.
Yeah, okay.
It seems, though, that people who maybe don't have good back health also can have herniated discs, and that means they don't lift correctly, or can something like that lead to it as well?
Great point, yes. For any type of mechanical stress that's above and beyond what the spine was designed to do, whether that's a one-time stress from a trauma or excessive lifting, or repetitive stress, like sitting at the back of a truck or in the driver's seat of a truck and seeing the vibrational forces over and over again over a long period of time in the seated position. And so there's certainly a mechanical piece to it. It is a nature-nurture, environment, and genes all playing together to result in this unfortunate event that happens to millions of people.
So there are lots of reasons that people have back pain. Most often it's considered muscular, or it's related to an arthritic process between the vertebral bodies. So what's the difference between that and a ruptured disc? What's the difference with regard to symptoms? How do you know your disc might have ruptured?
Well, and so it can be challenging. And so, part of understanding what's going on is doing a thorough workup. It starts with your primary care doctor and moving up. But when we rupture a disc, the material that comes out does two things to the nearby nerves. First, it puts pressure on the nerves. Any nerve that sees pressure tends to have one of three things happen. It can have pain in the pattern of the nerve, and so you get a sciatica kind of pain running down your leg in a specific pattern. Typically, when you tell your spine surgeon where it is, they can backtrack and guess what nerve we're talking about, because your legs are wired in a very specific pattern. It can also cause weakness, and it can cause problems with sensation, so you get tingling or numbness sensations. Any or all those can occur from the pressure, but also that disc, that jelly, is something that is very inflammatory, and so it inflames the situation. And one of our common treatments for a disc herniation is epidural steroids, or sometimes even oral steroids. And these
When
work.
you say epidural?
Epidural would be something that's delivered by an injection. And so the nerves sit in a sac called the dura. The space right above the dura would be called the epidural space. And so when we put steroid with an injection directly in that space, we're delivering steroid right on target, and we're giving the maximum amount of steroid we can to try and reduce the inflammation. So both the mass, or the pressure, and the inflammation leads to the symptoms. So the symptoms can be down the leg, and those, when you see a spine surgeon, are the ones that we're going to hone in on, because those are the ones that are most reliably made better and most reliably related to the disc herniation itself. The other symptom can be back pain, and the back pain could be related to the disc herniation or completely unrelated to it. And for that reason, the fact that back pain comes from so many causes, that we don't have a great treatment, and it's usually not part of our primary treatment strategy.
Is the MRI scan probably the best test to figure out for sure that it is a ruptured disc?
Unquestionably, yes.
And what percentage of these patients with a herniated or ruptured disc actually need surgery? I mean, don't most of them get better without surgery?
Great question, yes. About 90% of people will have these symptoms spontaneously improve within about 6 weeks of the herniation event.
And when you talk about surgery, I know we used to always have to do it open. You'd make an incision, you'd go down, you'd get the disc out. But now you can do it through the scope. And then there's a procedure called laser spine surgery. Tell us about that.
So in the end, what we need to do is reverse what's occurred negatively. So the negative effect was that pressure from the disc herniation and the inflammation from the herniation. And you relieve that by taking away that fragment. And so there's multiple ways to get down deep inside the spine. As we refined our techniques and our technology, we've been able to limit the collateral damage by reducing the size of the incision and the size of the dissection. But in the end, to make it better, we do need to relieve that pressure and that inflammation by removing the fragment. And so open surgical techniques and microsurgical techniques produce similar long-term outcomes. Microsurgical techniques produce an outcome that may be had in a quicker fashion because there's less collateral damage, less dissection. Other technologies using lasers or other minimally invasive opportunities leave the question of, did you actually treat the primary issue? And that is, did you remove the disc that was offending the nerve? Because if you haven't done that, then I challenge that you've actually done anything that was productive for the patient. And so that's not something we offer here.
All right, so the case for micro surgery might be a little bit overstated.
I think so. I think that any pretty picture of a Band-Aid on a back alone is going to be an underestimate of the impact of spinal surgery. It's a pretty invasive thing no matter how small our incision and how little dissection we do. Our spines are almost in the middle of us at our lumbar. And so from your skin down can be several inches till we get to the spine. And there's not something small or minimalistic about that approach that completely alleviates the pain of the surgery. But the pain reliably goes away within 2 to 6 weeks. Most people leave the same day or the day after surgery, and most people have immediate improvement in their lower extremity symptoms.
All right, and what a relief it is if you've ever had a ruptured disc to have that pressure taken off. We've been talking with orthopedic spine surgeon Dr. Brett Freedman. Dr. Freedman, thanks so much for being with us.
Thank you, guys.